Okay, this video presentation is for Module 11, Nursing 150. I'm going to cover multiple sclerosis and amyotrophic lateral sclerosis for this presentation. First, I'm going to cover multiple sclerosis. Multiple sclerosis is a chronic autoimmune disease. It affects the myelin sheath. That's the conduction pathway in the central nervous system. It's a chronic disease, and it is characterized by periods of remissions and exacerbations. These periods of remissions and exacerbations is different in every patient. And as the periods of exacerbations become more frequent, as the disease progresses, they typically have a normal life expectancy as long as they are identified of what the disease process is identified correctly and treated correctly. Different types of MS, the major types are the relapsing-remitting. About 80% of patients with MS have the relapsing-remitting kind, and it's basically they have exacerbations of it and then that goes back to a full recovery typically. The relapsing-remitting can progress to become the secondary type. About half of all people with relapsing-remitting MS develop secondary within 10 years. And again, that varies in patients on the treatment. If they're identified early and treated well, then that 10 years may be longer, and it can completely decrease the development of the secondary type of MS. We don't know the cause of MS. It's thought to be an autoimmune again, and there's some theories about some viruses that can cause it. They have not been able to identify a specific virus, but it does seem to be related to people who have had a viral infection. It is seen more in colder climates as well, around the Great Lakes and up in Canada. There seems to be a higher incidence of MS. This is just a visual picture of the healthy nerve. This is healthy nerve right here, and the myelin sheath is what covers right here. And then this is the unhealthy. And this is where it's damaged, and this is what MS does to the myelin sheath. And that way, then the nerve pathways are damaged. Again, just talking about the causes, we don't really know. It's thought to be related to a virus. The other thing that does seem to be a familial tendency. If you have a first-degree relative that has it, you're more likely to have it. MS has a wide variety of signs and symptoms. It is difficult to diagnose at times. They typically go through a gamut of ruling out other neurologic disorders before they end up defining the diagnosis as MS. Some of the early signs and symptoms, and this is what they'll start asking them questions about, vision, mobility, and sensory changes. Those are early indicators of MS. They're vague, nonspecific in the early stages, and that's why it's difficult to diagnose. And then you just have to kind of pay close attention to whether they are intermittent or becoming progressively worse. They need to kind of keep a documentation of how the signs and symptoms kind of appear. Because like I said, MS it has remissions and exacerbations, so that would fall along the lines of MS. A complete neurologic assessment would need to be done. On page 979 is a chart that has the key features of MS. Muscle weakness and spasticity is certainly common. The fatigue, a lot of people, that's what they'll complain of, and that's one of the most disabling manifestations, is the really profound fatigue that they have. Demyelination of the spinal cord has occurred. The patient will experience bowel and bladder dysfunctions, and this can be pretty profound and really kind of disrupt the patient's daily life. They will begin to have constipation or incontinence. The other thing to look at is their vision. They can have blurred vision, double vision, decreased visual acuity, so safety would be something to think about in these patients, as far as, are they still able to drive if they can't see well? How can we help them continue to be independent with these vision changes? Impotence is another one that can be life-altering and kind of, especially this occurs in younger people typically. So There is a table on page 980 that discusses the evidence-based practice regarding the impotence that occurs in a patient with MS. So basically, monitoring these patients, if they do have bowel and bladder problems and helping them manage that. A lot of times they're incontinent, they have constipation, so things that we do as a nurse to help with those types of disorders. It is difficult for the entire family to kind of to deal with. They're going to need some help. There is a concept map on page 981 as well that kind of takes a case study of a patient with it and kind of maps that out for you. So that's a really good tool to use to look at some of the interventions, especially like there's some vision interventions. It talks about wearing a patch and having the patient see an ophthalmologist. Also assist with bladder care. They might have to do intermittent catheterization and drawing catheters. Different types of things like that. Prophylactic antibiotics may be needed for the prevention of urinary tract infections. This picture is just another visual to just kind of help you understand the pathophysiology of how the myelin sheath is damaged in multiple sclerosis. Again, just talking about the psychosocial changes that occur. They do have cognitive changes that usually occur later in the course of the disease that need to be dealt with. Again, you can look at that in the concept map on page 981. It talks about doing a psychosocial assessment, talks about body image, self-concept, things like that to kind of help a patient to see how they're dealing and if they are having any cognitive deficits with it. There's no single specific diagnostic test to diagnose MS. That's why it is difficult to diagnose. There are some there are some things like a lumbar puncture where they get cerebral spinal fluid that can help differentiate it to rule it out and rule other things out, basically is what they try to do. If the cerebral spinal fluid has elevated protein, elevated white blood count, and if there's the presence of immunoglobulins, that typically indicates it goes along the lines of MS, so that would kind of help them confirm it. CT scan, it would show an increased density in the white matter. Again, that would kind of help confirm the diagnosis based on everything else that's going on with the patients. MRI and EMG, again, will help confirm that the patient is having signs and symptoms of MS. Electromyography, which is the EMG, will usually be grossly abnormal in patients with advanced disease. So they'll just kind of, once they suspect this is going on, they'll do like a lumbar puncture or CT scan to kind of help confirm their thoughts, their theory. There are some drugs, interferons out there that are given for managing the disease, and typically what they do is they're like antivirals to manage the signs and symptoms, or immunomodulators that help decrease that autoimmune. They are mostly injections that the patient will have to be taught how to self-administer. They're sub-Q, so that would be a teaching piece that would be involved in working with a patient that's going to be put on these medications. Other supportive drugs, of course, are going to be those prophylactic antibiotics for prevention of bladder infections, antispasmodics, anti-epileptics, NSAIDs, of course, for any pain or discomfort, and then the antidepressants, of course, for a patient who's dealing with this type of disease process. MS is a manageable disease. And like I said, the prognosis is good. They will have a normal lifespan as long as they are treated and supported well. So that's why it's going to take a lot of home care management, safety things for visual disturbances, making sure that their bowel and bladder is identified and treated well. Things like that. They're going to need a lot of rest. Again, like I said, the fatigue is very profound in these patients, and that's what is typically the most disabling piece of it. They get so tired. So teaching them how to cope and plan rest periods throughout the day so that they can deal with it. Lou Gehrig's disease, or amyotrophic lateral sclerosis. It is named after Lou Gehrig, as he was a baseball player, I believe around the 1940s, that kind of was the first face of amyotrophic lateral sclerosis. Stephen Hawking is another kind of famous face related to ALS. It's a disease that is progressive, very progressive. It's thought to be autoimmune, leads to muscle wasting, and eventually a paralysis that will eventually lead to a very, very poor prognosis. So the difficult thing with Lou Gehrig's is that we don't really know what causes it. We don't have a very good treatment or cure for it yet, even after all these years of kind of knowing what the disease process is. But basically what happens is loss or death of the upper and lower neurons. So that's how the paralysis occurs. And basically when the paralysis reaches the respiratory muscles, that's typically when it's very difficult to treat and it's a poor prognosis. This is just a visual of the neuron, what happens to it as the patient has affected by the ALS. This one is the atrophied muscle. So it's damaged and it just sort of atrophies, which means it kind of shrinks up, and so it doesn't work well enough to convey the messages between all the neurons. Again, just another visual of what it looks like with amyotrophic lateral sclerosis. You can see how this, as it atrophies, is not going to be a good transmitter of signals through the neurosystem, and so that's what leads to paralysis. This typically occurs in patients between 40 and 60 years of age. Again, we don't really know what causes it. It can begin younger, but typically it's 40 to 60 years of age. It's more common in men than in women, and I think it is kind of maybe related to some genetic, viral, or environmental factors, but we have not been able to identify a single one thing that we know is causing it. Typically, it's a little bit hard to diagnose. They start to have weakness and fatigue initially. There is a chart on page 983 that talks about the early clinical manifestations of ALS. Tongue atrophy, weakness of the hands and arms, and that's what, in my experience from talking to patients who have ALS, that's the weakness in the hands and arms is very common early sign of it. And then they start to have the muscle atrophy, some twitching of the face, some slurred speech, difficulty swallowing, fatigue, things like that are some early signs and symptoms of ALS. And at first it's kind of vague, and they might just think that they're just tired. They don't really recognize it as a problem in the beginning, and because it is kind of vague, and then as it progresses, then they kind of know that they need to go get checked out. Diagnosis is usually just based on a thorough neurologic history. The patients that I know of that have had ALS go through a very, very thorough, they rule out everything else. They go to a lot of specialists in order to be diagnosed definitively with ALS. CK is usually, which the creatine kinase, I don't know if you remember that. Those are like those enzymes that are released from muscle damage. And remember, the muscle atrophies in ALS, so the CK, the creatine kinase, will be increased in this situation. That will help confirm the diagnosis of ALS. EMG, again, that electromyogram, they'll test the muscles. That will help confirm it as well. Sometimes they'll do a muscle biopsy. That will show the atrophy of the fibers. So definitively, diagnosis is making sure that you rule other things out, and then kind of confirming it with some supportive tests like CK, creatine kinase, EMG. There's no known cure for ALS, and it's just supportive measures that we'll talk about in the next slide. There is one drug, Riluzole, that is approved by the Food and Drug Administration for patients with ALS. and it doesn't cure it. It can sometimes decrease the symptoms and extend survival time. It's an expensive drug. They have to take it with food, and it can damage the liver. So a lot of monitoring involved in that. Drugs. Most of the drug therapy is focused on relieving the other symptoms of ALS and keeping a patient comfortable. Pain medicine, fatigue, spasticity. They do have a lot of discomfort, fatigue. The excessive secretions, again, can be an indicator that of the atrophy of the muscles for their speech and swallowing and things like that, and sleep disturbances. So meds we could give for excessive secretions would be like those cholinergic meds, like atropine could be one. They do like atropine drops in the mouth that can decrease secretions. Pain, it could be NSAIDs, could be maybe more things like Vicodin. There's meds that can help the spasticity. Baclofen is a muscle relaxer. A lot of different meds just to kind of support the patient. The other piece of treatment is maintaining optimum functioning at the end of life care, and they really need to start having those conversations with palliative care. Hopefully, if palliative care can become on board, it's one of the best ways to help manage their end-of-life decisions, because they really need to start deciding whether, if it comes to the point that they can no longer breathe on their own independently, what they want to have done. Do they want to be intubated? Because typically what happens if they have to be put on a ventilator, they will never be able to come off a ventilator, because there's just no way. Once they've lost that ability to breathe independently, it won't come back. So they just have to kind of start working through that, and palliative care is one of the best ways to that team can help them kind of make those decisions and involve the family in helping them to deal with it as well. Lots of different things out there. And so as a nurse, you just kind of have to understand how we can support a patient through this type of, getting them the resources that they need to work through this type of decisions. And the key to doing that is just answering questions factually. Give them the facts so they can make informed decisions. And try not to be judgmental at all, and let them make their own decision, because it ultimately has to be them. And like I said, many people might elect not to be placed on a mechanical ventilator, and that's okay. And if they decide to, then that's okay as well. We just need to support them in a non-judgmental way and let them verbalize their feelings. Okay, that concludes this video presentation on MS and ALS.